Hi, I'm Dr. Keller, and this is Dr. Heisel.
Hello.
Thanks for coming on.
Glad we could be here.
Yeah, what are we going to tackle today?
Today we're going to talk about spinal taps. This can be a fairly daunting procedure early on in your training. There's a lot of mistakes I see people make, and so we're going to focus our approach on avoiding those pitfalls.
All right, well, let's get going.
So we're going to talk a little about obtaining consent. And I think it's particularly important when you're talking about lumbar puncture to make sure that your patient that you're doing this procedure can actually consent for the procedure.
Because the problem is what we're looking for may affect their ability to make a good or bad decision. So if you're going to allow them to say no to this procedure, you really have to do a good job of documenting that the patient's mentation was preserved, that they could really explain what you were worried about, and that they understood the negative consequences of not doing the test.
Absolutely. And you can always offer them sedation and making sure that you've adequately addressed their pain and making sure you've done a good job of making sure you've offered all abilities to make the procedure less scary.
This is, again, a place where you want to bring in the family to make sure they're also understanding pluses and minuses. Now, once you're moving forward, there are some things that we do want to tell patients that they're at risk for with this procedure.
Risk of headache is about 10%, and then there is always that fear of having to have creating a leak and then needing to have a blood patch done, and that risk is about 3%.
Yeah, I do tell patients that the needle that we use is the same width as what we would use to put an IV in a baby, so it's a very narrow needle, but that procedure is sometimes required. The other thing I always warn patients is there is a small chance that you do this test and don't get fluid, especially in infants, where you can feel the pop, know you're in the exact right spot, and there's just no fluid there because they're dehydrated for whatever reason. So I always let patients know there is a chance that we do this procedure and yet don't get the answers we're looking for.
And I don't know about you, but I'm a strong advocate of letting family, if they want to, be in the room as long as they're in sterile precautions and they're calm. I think it really helps build an element of trust when they come in the room with you.
I agree with you. My rule is, though, they must be sitting down, and I keep them on the other side of the bed because this procedure, more than any other, I have family members face plant, and then you have two patients to deal with.
Good safety tip.
So as we begin here, let's talk about positioning. In the sitting position, it is helpful to have somebody actually at the front of the patient help the patient maintain the proper position throughout the entire procedure. What can happen is you can start with the patient in the correct procedure where you're feeling the spinous processes and they're bent correctly. However, as the procedure goes, the patient has a tendency to lean forward, and this is going to make the procedure almost impossible.
What I tell patients to do is make sure they're keeping their shoulders drooped down, because as soon as they're bending at the hips, then the back is turning the wrong direction. So they've got to bend at the back, not the hips. So the most common positioning is what we just demonstrated of sitting up. Now, I was always trained to do it lying down because number one, you can check the pressure, and number two, then you don't need an assistant. Now that I'm an attending, I can get a tech anytime I want them, so I do them all sitting up. But we're going to show you some pearls about lying down positioning as well.
In the lying down position, one of the biggest tips that we can give you is making sure that you're paying attention to what's happening to the patient's shoulder. Dr. Heitz is going to demonstrate what can happen is that the shoulders can actually roll and actually twist and mess up all your landmarks and make this procedure very hard. So make sure you're paying attention to the patient's shoulder that's facing the bed and keeping it in line. The other important point is making sure that when you're doing this procedure that your non-dominant hand can actually palpate the structures while your dominant hand is actually can do the procedure. So now we're going to talk about sterilizing the area. One of the most important aspects of sterilization in this procedure is making sure that wherever your hands may be, that you've cleaned that area appropriately. So making a small area that's sterile here, where your needle is going to go, is not going to cut it, because your hands potentially can be all the way out to the hips, because that's where you're going to be feeling your landmarks during this procedure. So it's very important to make sure that you prepare a wide area where your hands could potentially go.
In any procedure, one of the most important things is to set yourself up correctly for success. So if you're intubating, make sure you have the head of the bed at a level that works well for you. If you're doing a central line, make sure you have your equipment laid out correctly so you're not having to cross over your arms to get your dilator or your wire. With a spinal tap, you want to make sure you've got your tubes out and ready, and you've got them in the correct order. That the tubes are labeled 1, 2, 3, 4, and you must know which came in which order so that you can make sure that if it is a tad traumatic, that you see that blood clear sequentially. So make sure that you've got these tubes set out in the correct order that you're going to take them in, and ready for you to be able to reach over and grab them and change them out once you're getting fluid. One quick note about the needles. It's frequently a 20 gauge needle that comes inside the kit. I generally use a 22 gauge needle that's a much smaller needle, and so I'm less likely to get a spinal headache. If you have access to the pencil tipped rather than the cutting tip needles that we use here, they have an even smaller rate of post-dural headache. And if you're able to use a 25 gauge pencil tip needle, you're nearly guaranteed a champagne tap if you can accomplish the tap with that very thin needle. It usually works only in very thin patients. So you have your patient consented, you have your patient prepped. Now you're ready to get the patient numb. And this is another place where I see people make a common mistake that really makes their life more difficult. When you're using the lidocaine, what are you really trying to do? Because you're numbing up for a very small needle. So here's a rude diagram. Your spinous process is here. There's a ligament that runs along the posterior aspect of the spinous processes. And then you've got your skin surface here. You're attempting to palpate these vertebral prominences to know where you're going to insert your needle. Too many people I see leave a ton of lidocaine here in the subcutaneous space and don't actually get any lidocaine beyond this ligament. So most of the area where they're inserting the needle won't have any lidocaine there. And then if they encounter bony resistance, now they've obliterated their landmarks. You're not going to be able to feel these spinous processes because you've got a giant wheel of lidocaine here in the subcutaneous areas. So when you're numbing someone up, make sure that yes, you want a little skin wheel here, but more importantly is to get some lidocaine distal to the spinous ligament because that's where the numbing medicine needs to be. So now we're ready for the moment of truth. You're going to insert that needle and you're going to hope to get clear fluid out. So where do you actually insert the needle? When you look at someone's spinous processes, when you look at their back and the next lumbar x-ray that you get of someone, really look at the shape of those vertebral processes to help you visualize what you're going to be doing the next time you do a spinal tap. But when you're looking at those vertebral processes, you'll notice that kind of the most prominent bump isn't dead center. It's a little bit kind of towards the caudal aspect of the vertebrae. So where you're feeling those bumps from the outside, I usually like to insert my needle not exactly halfway between where you're feeling those two bumps, but a little bit below, maybe about 60% of the distance between where you're feeling those prominences. And then you're going to angle your needle up about 10 degrees above horizontal, aiming for their belly button. And then you're going to slowly advance it, hoping that you then find fluid before you meet bony resistance. If you do hit bone, this is another big mistake I see people make. They come back a little ways, and then they try to re-angle from the outside without pulling their needle back, and they're doing one of two things. You either bend your needle, and so you're then just going to follow the exact same track because all you're doing is bending your needle back here, or you're taking that needle tip and moving it in a however many degree angle to re-angle, and you've just used that cutting tip as a knife. And so now you've basically assured yourself of getting a traumatic tap. So if you do have to re-angle, you want to come nearly all the way out to within about a 1/4 inch of the skin surface, then re-angle. My usual approach is about 10 degrees higher than my original attack angle. Go ahead and advance your needle. Hopefully you get fluid now. If you don't get fluid then you come nearly all the way back to within a 1/4 inch of the skin surface. Re-angle, I usually go about 10 degrees below my original attack angle and see how far I get. At that point, then you've got to decide what angle gave you the closest approach, the deepest approach, and how do you need to reposition? Do you need to come all the way out and move your needle insertion point up or down just to try to visualize where it is that you're encountering bone and what you have to do to find that angle to get clear fluid. So we're feeling over the hip processes, we're feeling with our thumb between the spinous processes. We're going to insert our needle after numbing the patient up and after using the iodine prep. We're inserting with the needle bevel sideways. I usually steady the needle with my dominant hand to advance it, to keep it from bending, and then use my non-dominant hand to put some pressure at the end of the needle to push it in. There's two schools of thought. You can either just advance until you feel the pop, or you can advance until you're about halfway there and then just start checking every kind of quarter inch or so. If you're checking, make sure you give it a good second or two for fluid to appear, because it doesn't always show up right away. That you can be in the right spot, but it's a tiny little needle and it takes fluid time to show up. There is some school of thought that after you've passed the dermal layer, once you've passed that spinal ligament, that you can advance the needle with the stylet out. Now, you have to realize if you drag any dermal cells from the skin layer into the spinal canal, they will take root and sprout a tumor there, so don't do that. A lot of times when I see residents attempt to advance the needle with the stylet out, they just get a fat plug in the needle and they're unsuccessful. So while it works well for infants, I don't see it work as well for adults. We're going to expect that we probably got fluid right about here. My dummy's out of fluid, so we're not actually going to get fluid. Once you've gotten the fluid started, put your stylet back in. You don't want to waste a drop of that spinal fluid. Every drop you lose is one drop closer to a spinal headache. We've got our first tube here. My usual approach to collecting fluid is I put the back of the collection tube against the tip, against the open end of the needle to kind of milk fluid out using kind of capillary motion. I find that people try to coapt the front lip. That would be more intuitive. The fluid will kind of just go along the spinal needle and then track off and drip off. So if I maintain contact with the actual rim of the collection tube with the needle, that I don't lose fluid. There is a technique to being able to reclose your tubes with one hand as you're swapping them out. I generally collect a little bit less than a cc in each tube. That I usually don't let the meniscus get all the way up to the 1 cc gradation. So my usually meniscus of fluid is about 2/3 of a cc, so I end up with about 3 cc's of fluid spread over 4 tubes.
We're done.
We're done. We wanted to just reiterate those 3 big mistakes we see people make. Number 1, make sure that your patient is drooping down rather than just leaning forward at the hips. Number 2, don't obliterate your landmarks with lidocaine. And then number 3, on the off chance your first approach isn't perfect, if you do encounter bone, bring that needle nearly all the way out and then re-angle rather than just trying to bend the needle inside this patient.
And I would just add a final point is to not get overly frustrated if you fail, because even the best can fail at this procedure, and it does get frustrating, but just know that you can do everything right and not get fluid, correct?
That is so. We hope we found this helpful, and tune in for our next video.